If you're like, oh, I'm going to get side effects, my mom got side effects, whether it's a real side effect or a nocebo side effect, I will address it and I will take it seriously and I will not let them suffer.
Dr. Stephanie Saucier is a leading cardiologist who is changing the way that we think about cholesterol management.
Studies that get published, a lot of times they get published for the people who want the results published. So you can kind of find papers out there supporting both sides. If my lipids were high, I would be on a statin in 2 seconds flat. Key to changing the fact that heart disease is the number one killer of people.
Before we dive into this podcast, I do want to make sure that you're aware that we are going to make this CME accredited, which means that if you are a physician, nurse practitioner, or nurse that wants to get CME credits after listening to this, you can go ahead and click the link below, whether you're watching the video or listening to the podcast. And we do appreciate it. This is a new and growing show, and our goal is just to put out quality information, really tackle tough questions that we have in healthcare, and bring on qualified professionals like this to really have an engaging conversation. So if you wouldn't mind subscribing, following along, we really appreciate it. Let's get into it.
So first, tell me, why should physicians even care about this conversation with cholesterol? Why is it important?
I think physicians should really care about this conversation, and why we should care about cholesterol is because you're going to have patients who have a lot of questions. You're going to have patients who come to you with really well thought out questions and concerns about both their health and ways to protect themselves, but also about their medications and what potential medications they might be prescribed or on. And so it's important that you're prepared with the knowledge and have a good grasp on why this is all important and how you can make sure that you're giving your patients the best care, because at the end of the day, that's what we're all in this for, right? We all want to learn a little something extra and just take really good care of patients. And so that's why it's important for everybody, whether you're a primary care doctor, you're a cardiologist, you're a learner. This is something that's going to come up at every stage in your life.
Fair enough. Okay. So just in case someone were outside of a primary care doctor or a cardiologist, say they were an orthopedic surgeon, a neurologist, should they really be even looking at cholesterol?
They might not necessarily be looking at cholesterol as something that they're taking a look at, right? But they might have a patient come in and ask them questions about their cholesterol or a level. Say their PCP ordered a lab or their cardiologist ordered a blood work that they didn't get a chance to review with their primary care doctor yet. But as the orthopedist, you're the one seeing them, right? You probably should have a good idea of kind of just where to guide someone or what information to give them, whether or not you're checking it yourself. And, I always encourage like my vascular surgeons and my neurologists. Yes, you guys should, guys and gals should 100% be checking lipid levels, because these are the patients with peripheral arterial disease, patients with strokes. Cholesterol matters to them as well and all of their patients. So it's not just a PCP problem. It's not just a cardiologist problem or a lipid specialist problem, but we all have to play our part to take really good care of patients.
Amazing. Okay. So let's dive into probably the number one controversy, maybe not, is that with statins, right? And so number one is statin intolerance. Is it a real thing, or is it mostly a nocebo effect?
So every medication that we prescribe, no matter what it is, has a risk of having side effects, right? Not every medication fits with every patient perfectly. And so there is a degree of certain side effects that are specific to statins that are very real and are true, and they make people feel poorly. And it's a very small percentage though, right? So when we look at the studies looking at statin, let's talk about, like, for example, statin myalgias, where muscle pains, right? Myopathies. When we look at the studies of statin myalgias and myopathies, the rate in the studies was around 5%, right? What we know though is we know that in kind of clinical practice, we see it at least 10%. And so what that means is that if you're in a room of 10 people, at least one person has had those muscle aches and pains from statin and then write statins off and hate them and are very vocal about how they hate their statin and it ruined their life in one way, shape, or form. So yes, there are real potential side effects. There's also some very rare real side effects of these medications that occur, less than 1% of the time or even 0.5% of the time. But all in all, most people tolerate statins very, very well.
So then, with that being said, say a patient they're taking a statin and they are complaining of these myalgias, which could or could not be due to that statin. How can a physician really differentiate between real statin intolerance based on more of a psychological or more a musculoskeletal response?
Okay, so that's exactly what a lot of times we face is you put someone on medication and they say, okay, I'm having, muscle aches, pains, weaknesses. I can't move, my shoulder hurts or things like that. Now, what we know about statin associated myalgias is that most of the time, and it's not all of the time, but most of the time it's in the proximal muscle groups, the large muscle groups. So your thighs, your upper arms, your glutes, right? And the nice thing about statin-associated myalgias is when you stop the statin, it should go away within 4 weeks. The quicker that it actually goes away, the better. It shows that it's more related to the statin potentially. And then the other thing is we like to retrial patients. So if you've had a myalgia to a statin in the past, what we want to do is we want to retrial someone. If someone then has really quick response where they're having muscle associated side effects quickly with restarting a medication, that's going to give you some more points to suggest that this is a true statin associated myalgia compared to patients where they kind of work it up in their head and there's that whole nocebo effect where it's not you know that it's a side effect, and so of course it's going to happen to you, right? And so it's kind of the self-fulfilling prophecy, as we like to say, right? If you're like, oh, I'm gonna get side effects, my mom got side effects, my dad got side effects, you might not get
Mhm.
side effects. But it's important that we differentiate those things. So giving a trial and error, I will take patients off of a statin. I'll give them a holiday and say, okay, let's see how you're feeling off of the medication. If your symptoms go away within 1 to 2 days off of the medication, okay, maybe it is. But if I take you off the medication and 4 weeks later, 5 weeks later, 3 months later, you're still having that shoulder pain, guess what? I'm gonna send you to you. I'm gonna send you to a physical therapist. I might send you to an orthopedist because at that point, it's very, very unlikely that the myalgia is related to the statin, right? The other thing is, as clinicians, we should be clinicians. We should be objective. And so I also check CK levels. I want to make sure that there is no muscle breakdown, that there is no buildup of CK in the blood. So I'm going to check that, and most patients don't have elevated CKs associated with their muscle aches and pains. But if they do, then we really have to be thinking of kind of more serious or potential side effects that the patient may be having. So those are some of the things that I do to try to figure out if this statin associated myalgia is real or if it's more kind of, related to another problem, an orthopedic issue or rheumatologic issue, et cetera. I had a patient one time who had a lot of muscle aches, pains, and, we took him off, we gave him lots of holidays. And ultimately, they actually got diagnosed with PMR, which is polymyalgia rheumatica, and like 2 milligrams of prednisone, and they were perfect. And their rheumatologist diagnosed this, and this was off of meds, and so you don't want to go in with a bias, right? You don't want to anchor. This anchoring bias is dangerous, and so you want to make sure you're being objective and taking a look. There also is something called the Statin-Associated Myalgia Scoring System, or the SAMS scoring system. And it's a nice objective way that it's a tool providers can use. You could pull it up on Google or whatever med calc you like, and assess whether or not this is a probable or likely true statin associated myalgia or not.
Okay, I gotcha. And then once you've determined if it's a myalgia or not, you can determine whether or not you need to go to like the next line of defense, or if it wasn't caused by it, then at least get them the treatment for whatever actually was causing it. That's right.
Absolutely. Yeah. We want to make sure that people are being treated for whatever the underlying problem is. And sometimes it's a dose issue, right? Sometimes people respond to a higher dose of statin and they have more side effects to that than they would at either a lower dose or even an intermittent dose, right? So there are papers out looking at the use of Crestor a couple times a week or 3 times a week, like low dose. You get a pretty decent LDL reduction using some of these longer half-life statins a few times a week. And so sometimes patients tolerate that better. Sometimes
Mm.
patients tolerate lipophilic versus hydrophilic statins. And so sometimes I'll swap in between classes just to try to see what the patient is responding to and what they're having more side effects with.
So what do you do when a patient comes into you and they may have high levels of cholesterol, but they saw some influencer online talk about how it's really bad for you, how it causes all these problems? What do you say to them?
Yeah. So I tell them to give me a chance. I tell them to kind of come with an open mind. And I also make a promise with them. So I make a promise with them that anything I try to do or give them is not my intention to hurt them or make them feel poorly. And if they do have a side effect, whether it's a real side effect or a nocebo side effect, if it's a side effect they feel like they're having, I will address it and I will take it seriously and I will not let them suffer. I won't just say, you have to stay on this medication. So that's a promise I make with the patients is like, okay, I'm going to trust you. You have to trust me. And
Mhm.
let's have that relationship to like really just give this a try. I also nicely remind them that there's other drugs out there, right? There's other medications we can use. This is just a starting point, right? We have to start somewhere. And so starting somewhere, we start with a medication that has been around for a long time, is really safe, and has been proven to lower risk of heart attack, stroke, and death. Obviously, no study is perfect, but over many, many years, we've seen the benefits of, statins, including anti-inflammatory benefits. So I think when patients come to me and are hesitant or they've seen that influencer who gave statins bad PR, I try to change the script. And I also try to make sure that the patient and I have a good relationship, that we can trust each other and make sure that we're going to give this a try together.
I think that promise that you're making to them probably really elevates the
Yeah,
level of trust that they have in you, and meaning like, okay, I'm in good hands with someone that has researched this, who's dealt with it many times before. And I imagine that helps them kind of overcome that psychological barrier. So that's amazing. Um,
absolutely.
you know, uh, I want to now jump into another subject that I know that you are passionate about. And tell me, LP little a, should everyone actually be tested for this?
Yes, 100%. LP little a is, um, we know that this is an independent risk factor for development of stroke in young people, atherosclerotic disease, and aortic stenosis in the middle-aged population. And so we also know that it's predominantly genetically determined. So we have the opportunity. This is a very unique case with LP little a. We have an opportunity to identify a cardiovascular risk factor when you're young. And therefore, we can then make changes when you're young. We can modify your risk of developing heart disease. Out there, I think I see sometimes on social media where people are like, I want to do this whole body scan and figure out if I have cancer or not. And I want to do these biomarkers that test 120 different, biomarkers. Hey guys, this is one biomarker that we know is a risk factor for heart disease, and heart disease kills more people than every cancer combined. So before we start scanning our bodies for, cancers when we're really young, which again might be, beneficial. It's not, we're not going to chat about that here today, but why don't we do a very simple blood test that you need only once in your lifetime if it's normal, and see what your risk is for development of heart disease?
So I guess tell me, for anyone who's listening to this or watching this and they don't know what LP little a is, at least give a quick background of what it is and why this is actually important.
Okay, awesome. So, what LP little a is? Little a is a predominantly genetically inherited form of cholesterol. Essentially, it has a makeup similar to LDL, but it has this kringle tail that makes it quite atherogenic, and it also makes it pretty sticky, and it also makes it increase your risk factor for heart disease. So, kind of in a quick down and dirty, that's what it is. It usually hits its adult level by age 5. And so people are exposed to this LP little a for their entire lifetime. Women, when you're pregnant, if you have elevated LP little a, it does also potentially double during pregnancy, but then will return back down to your baseline levels postpartum. And then also in women, we see that there is another rise in LP little a postmenopausally. So that's kind of just some of the information about like what it is.
Gotcha. Okay. Now, the difference between LP little a and LDL is that for LDLs and, we have statins and medications for it, whereas LP little a, we don't have anything that's yet approved for the public. Is that right?
So that's right. Yeah. We do not have any FDA approved medications that treat LP little a. There is an FDA approved treatment for LP little a in patients with familial hypercholesterolemia, and that's LDL or LP little a apheresis. Now, that is a form of basically it's apheresis. So, what we do is we actually clean the blood, we send your blood through a filter that filters out the particle sizes for LDL and LP little a. And essentially, what it does is that then we put your blood without your LDL and LP little a back into you. Um, and depending on what your disease process is, we may do this once a week or once every other week. So you're right. There's no FDA approved medication just yet. They are in clinical trials, which I think is exciting and we can chat about. But there is an FDA approved treatment if you have familial hypercholesterolemia and LP little a.
So my next question would be, for example, my mom recently went to the cardiologist and they tested her for LP little a. They notified her that her LP little a was elevated, which puts her at higher risk for heart disease, heart attack, all that stuff.
Yep.
And she left scared. She left scared
I
because when
know.
a doctor tells you that they're now a higher chance of dying, but we don't have a medication to give you, then how much benefit are we getting from testing something like this when we don't have yet a treatment for it?
So the benefit of testing is that you can modify other risk factors, right? We can often modify LDL to lower. So when we're lowering your LDL with you, if we know that you have high LP little a and we get that LDL down as low as we can possibly get it, I really aim for less than 70 in my patients with high LP little a. So the first thing is we can modify your risk factors, right? So we can put you on
Mm.
statins and other medications to drive down the LDL. So that's something we can do in real time that you might not have needed if you didn't have your LP little a tested, right? And then the
Sure.
other thing I always tell patients is that there's hope, right? So in the very near future, you may see drugs that get approved for the treatment of LP little a. And the reason why I say that is because right now, at the moment of this podcast, there are 3 drugs that are in phase 3 clinical trials for the treatment of LP little a. My practice, we're involved in 2 of those clinical trials. And so, there you might be a candidate for one of the clinical trials. And also they're coming, right? These trials are coming out to see, hey, now we know that we have LP little a and these drugs lower LP little a, but does it matter? Does it lower the risk of heart attack? Does it lower the risk of stroke, right? And so I try to always give my patients hope. I also offer them if they're interested in joining a clinical trial and they qualify. And then I take their risk factors and we're aggressive, right? We're going to make sure your blood pressure is perfect. We're going to make sure your sugar is great. We're going to make sure your LDL is less than 70. And there's some data out there looking at the use of aspirin in patients with high LP little a, and there's some really promising data there. So, although aspirin isn't for everyone, it's not for all comers anymore. And we know that based on the US Preventative Task Force. For patients with high LP little a, it's a conversation and it's something that says, hey, we might be able to also use a baby aspirin a day to help reduce your risk, based on
Right.
all of the other things that we have going on. So knowledge is power. And I think that one thing that, one of my favorite quotes, and you've heard me say this before, is, knowledge is the enemy of fear. So when your mom's afraid, I like to give her knowledge and give her encouragement that you're going to be okay and we're going to treat you and we're going to be aggressive. And there's things coming down the line. But also I often try to also, talk about the future of their kids, right? So your mom might be, I don't know, 50s, maybe even early 60s or younger when she gets diagnosed with Lp(a). But guess who that's important for, right? That's important for you. And so by her knowledge, by her knowing, you get to get tested, and you get to, if you do have high Lp(a), you get to modify your risk early as well.
That is really important. And I kind of wish that the cardiologist would have had a conversation like that. But that's where us having conversations like this can hopefully bring awareness to any other healthcare provider that if you're going to give news like this to someone that does put them at higher risk, it's really important to spend that little bit extra time. I know it's really hard, but just to explain and put them at ease, because this is really scary stuff, especially when it comes to cardiology.
Yeah, I agree with you. I think that, taking a little bit of extra time when you're giving bad news, right? I think, unfortunately, giving bad news is an art form, and it's not necessarily taught in medical school. It's taught in clinicals, like your residency and your medical school clinicals and things like that. But having that compassion, I just strive that other providers also will say, take the time, because maybe it's your mom getting bad news, right?
Right. Yeah, exactly.
Putting yourself in their shoes.
Yeah, absolutely. I agree with you 100%. Okay, let's move on to the person that really wants to try to figure it out, saying, you know what, okay, you have these high levels and you want to put them on a statin, but they say, you know what, I really want to try it with my diet first and see if I can fix it. Now, really my question is cholesterol from food a real concern, or is that like an outdated myth?
It depends. So, it's not that easy. I think you're gonna, someone out in the world on the big bad social media sites is gonna probably hear this and listen to it and disagree, and that's okay. And they can parody this. You're gonna find groups that say, yes, vegan is the only way to go. And you're going to find groups that say, no, it doesn't matter what your dietary cholesterol intake in, carnivore diet's the way to go. Then you're going to find some of the middle of the road people who are like, just Mediterranean diet, right? And so I think the answer is more nuanced than yes or no. And the answer comes down to knowing someone's genetics and knowing how they process their cholesterol. Right? So not all people tolerate an ingestion of high cholesterol foods in the same way. And that might be plant sterols. That might be, red meats. That might be fatty foods, right? So every person's a little bit different. My patients who have familial chylomicron syndrome, right? This is a rare genetic condition. But with this rare genetic condition, the recommendation is to eat less than 20 grams of fat a day. So absolutely, my patients with FCS can't just eat whatever degree amount of cholesterol that they want to eat. They can't, because they're going to end up in the hospital and they're going to end up with pancreatitis. Or they're going to be in a lot of pain, and their triglycerides are going to be 4,000 or 8,000, and we're going to be doing emergent plasmapheresis on them, right? So those patients, no, you can't just eat whatever you want. Now, there are other patients who, yes, their body naturally metabolizes their cholesterol appropriately. They have, good LDL receptors, and they have enough LDL receptors, and things are fine. And yes, then you can go on let's say a keto or a carnivore diet and not have the same issues. And so again, the answer is more nuanced. It's more about individualizing patient care and not being so black and white, right? Because we have to be specific about individualized care. We can't say blanket statement, no one, you can eat as much cholesterol as you want. And we can't say blanket statement that certain people can't. So the answer is not so black and white. I guess I didn't really give you an answer on that one, because there's just not a good one.
No, you did. You gave me the real answer, because
that's the real answer.
The ones that give the saying this is the one and only way to do it, they do really well on social media because it gets some really good attention, and you're like, whoa. But then you take a step back and you're like, they're not explaining everything. Because in my understanding of what you're telling me is that, could the carnivore diet be good for someone? Absolutely, if that's how their body specifically processes it, right?
Correct.
But to say that for everyone it's dangerous.
It's wrong. Yeah, it's very dangerous. Right. It could put someone in the hospital, right? So if someone who has undiagnosed FCS or a lipid metabolism problem all of a sudden goes on a carnivore diet, they might end up with an LDL of 300. They might end up with
Mm,
triglycerides of 8,000 in a hospital with acute pancreatitis, right? So you're right. Things that are popular are polarizing, and I think one of those things that I'm never going to be is necessarily polarizing, because I think we should speak to the facts and we should speak to the data.
yeah,
And every person's different.
true, true. Is there
Yeah.
like, so say your patient says, I want to try to figure this out and figure out which kind of foods work for me and my body. Is there a system or is there a professional that you would send them to, like a dietitian or a nutritionist that can really help guide them with that?
Yeah, I have some phenomenal dietitians that I work with. Um, and so typically that's what I'll do is I'll set them up with a dietitian. I'll give them some recommendations. And then people who are dead set on trying one specific diet or another specific diet, sometimes it's a little trial and error, right? And maybe that means getting blood work after 4 weeks on a specific diet, on a strict diet. Maybe that's you try something and okay, let's retest your blood. Let's make sure that like nothing's changing drastically, or hey, maybe it's changing for the good, right? In a good way. But it's really collaborative. It's multidisciplinary. If it's something I don't know, I have no problem sending them off to a dietitian or a specialist. But that's what I would do.
Gotcha. Okay. I don't know if there are cross-cultural studies that compare cholesterol levels based on the different diets, and whether or not if the American diet typically if we have higher cholesterol levels than say someone in Mediterranean. Do you know if they do have anything like that?
They do. I mean, there's definitely a lot of papers out there comparing all of the different types of diets and, different countries as well. And so I think that, again, it really is individualized, also culturally. And sometimes there are religious dietary constraints as well that we need to take into consideration when we're making recommendations. So
Sure.
yes, there's definitely lots of papers out there. You could get into the weeds. We probably could do a whole hour just on comparing, you know, carnivore versus vegan versus Mediterranean versus DASH.
Sure.
We could probably do a whole hour on that itself and really dig into the different studies, because you have to remember studies that get published, a lot of times they get published for the people who they want, the results they want get published. And so you can kind of find papers out there supporting both sides. And yeah, you
Yeah,
can find
I
cardiologists
hear
out
you.
there that also are very pro one side or the other.
Yeah, it's important to look at who's conducting the study and what is their goal of the study for sure.
Yeah,
There's bias in science as well.
there
Okay,
is
so tell
bias.
me, so if we say for one person, their cholesterol levels are elevated, right?
Mhm.
Say that diet does not help it. And then we find specifically like in middle-aged men who typically can have higher LDL levels, is there any merit to saying, should we just be giving statins to everyone over 40, regardless of the level of the cholesterol level?
No, I don't think that everyone needs a statin over the age of 40, regardless of your lipid levels. I think that, you know, I the guidelines are in place for a reason, and I think they're pretty reasonable. I tend, as a lipid specialist, I tend to be a little bit more aggressive, and really take into consideration additional risk modifiers such as inflammation, high sensitivity CRP, ApoB levels, things like that. But I don't think everyone just blanket needs to be on a statin, you know. But I have to say, um, of some of the patients that I treat, one of the things that gets requested a lot is, statins in certain patients.
Really?
Yeah, yeah, yeah,
Why?
yeah.
Why?
There's a certain population of patients that I treat who are definitely, they've read the data, they've treated the patients, and, they're here for a statin, and a lot of times they wanna be on one pretty quickly.
Who's that? Can you say?
My doctor patients, some of my doctor patients, yeah. Yeah.
Yeah. Okay.
My patients who are doctors, they're not afraid of statins. So,
Okay.
yeah.
That says a lot right there, doesn't it?
Yeah. I mean, I think it does,
Yeah.
but yeah. I can tell you that, I'm French Canadian. And so French Canadians, about 1 in 50 French Canadians have genetically inherited terrible cholesterol or hypercholesterolemia. So we can blame many, many generations behind us. But being French Canadian, I know that if my lipids were high, whew, I would be on a statin in 2 seconds flat.
So tell me, what should then, with that being said, what panel, what basic panel should everyone be getting? And when should they be getting it?
So the basic the basic panels that I do in my practice is I do a basic lipid panel. I do a high sensitivity CRP. I get a creatinine, which is your kidney function. I get an ALT, which is one of the liver function tests. I get an ApoB, which looks at the number of really the bad particles in the blood or the atherogenic particles. I also get an LP(a) on everyone at least once. Um, yeah, I think. Oh, and I get a thyroid. If you're seeing me for the first time, I also get a thyroid function test as well. And the reason
Should
why
Okay.
oh, yeah.
No, no, go ahead. Sorry.
Okay, I was gonna say, so the reason why I get some of those, more specific things are I get a CK on everyone too, usually, if their insurance will cover it, and I also get an A1C. So I get a lot if
Gotcha.
you're coming to me, you're getting quite a few blood tests.
But do you think, like, should all PCPs be ordering the same panel?
Yeah, I do.
They should. Okay.
They should. We had a little
It
criminal.
it
You want me to kick him out?
No, 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 it's alright. That's Huckleberry in
Okay.
the background, probably the
That is
sweetest dog ever to
Huckleberry in the
live.
Oh, sorry, guys. Yeah, so I do think PCPs should be getting these things tested. And it's interesting because I've actually met some young patients who are like, my PCP didn't even want to test my cholesterol, right? But if you look at the recommendations is that all adults, so aged like 18, 20, should have a lipid panel. Now, A1C is a little bit more complex. The insurances don't cover it for everyone unless you have risk factors such as obesity or other kind of symptoms, or if you have a fasting glucose that's elevated or elevated triglycerides. But I think that yes, a nice risk assessment panel never hurt anyone, right? If you find something, then you can address it and you can make sure that you're taking really good care of your patients or sending them to the right place, right? Like if you don't know what to do with an LP(a), then send them somewhere that's going to be able to treat them. Or if you have a high sensitivity CRP that's elevated, either, you know, learn what the risk assessment with that is, or again, shoot them over to someone who kind of knows better. But having that information before someone walks into the office is super important.
Sure, sure. So say if they are a PCP or say a hospitalist and they run the general panel, at what point do you feel that they should warrant a referral to cardiologist, someone specifically with a lipid specialty?
Yeah. So I typically think that someone should come to a lipid specialist if you're having trouble managing the cholesterol, right? So PCPs, they should be able to start treatment. They should be able to, start off and say, okay, like let's start a statin or let's try a second statin. The people who come to me are typically if you're struggling to get cholesterol levels under control, if you're having significant side effects, that you just don't know what to do with. If you have someone who has heart disease, obviously they should be seeing a cardiologist, right? If you have someone you're concerned for genetic hyperlipidemia or some of the rarer conditions, then, send them over to us as well. But a lot of the medications out there now have been around for a long time. And not just the statins, not just ezetimibe, but even your injectables, like your PCSK9 inhibitors have been out since 2015. They're not new medications anymore. So PCPs, in my opinion, you have a really good opportunity to have that rapport with the patients. They might not need to see a cardiologist. I always like to empower PCPs that you can do this, right? And you can help your patients really manage their lipids and their risk factors, their risk for heart disease.
So what framework would if you're encouraging them, is there like a framework that you can give them to say, hey, if they have these high levels, you can start the first line of defense is the statins, but if they can't
Mhm.
tolerate that, then here's X, Y, and Z. Is there a framework that you think about?
Yeah, I mean, typical framework for me is, if you have someone who needs, you want to first know what the goal is, right? So, based on the patient's risk profile, you want to know what their goal LDL is. So, is their goal LDL less than 100? Is it less than 70? Or is it less than 55? Those are kind of like the big three markers for LDL management. And so, also, it's important to know just mechanistically what reduction you typically are going to see with each medication. Okay. Because that's going to help you figure out how many meds you're going to need, how far you're going to need to go. But I typically say start with a statin, start with a good statin that has a pretty long half life. Either atorvastatin or rosuvastatin are usually my go to for my first two. Give one a try. Give a pretty decent dose. Don't go for the highest dose right off the bat, right? That just you're setting yourself up for someone to have a side effect. Start
Mhm.
at a reasonable dose and try to get the biggest bang for your buck, meaning you want to see the most amount of LDL reduction for with the lowest positive side effects. And so I always say start with statins. Like I said, either atorvastatin or rosuvastatin. And you should be rechecking lipids within 4 to 12 weeks after a medication change. So you shouldn't be letting these patients go 6 months a year and then rechecking their lipids. Like you should be checking them within 4 to 12 weeks by the guidelines. Then, depending on how much additional LDL-C lowering you need, that's when I then pull for additional medication. So, for example, if someone has we're gonna use easy math because, we don't wanna get too into the weeds here. We don't need
Yeah.
calculators.
No,
We're
no.
gonna do easy math. So if you start with someone who has a genetic or familial high cholesterol, they start with an LDL of 200. You put them on a high intensity statin that they're able to tolerate well. Typically, you should get about a 50% LDL reduction with that. So you're gonna bring that LDL from a 200 down to 100, okay? Say your goal is to get them less than 100 because they don't have a lot of other risk factors, then maybe adding ezetimibe or Zetia is not a bad idea. That gives you a 15% additional reduction, 15 to 20 depending on the person, and you'll bring them down under 100, right? If you have someone who has diabetes where their goal LDL is less than 70, then adding that Zetia to get a 15% reduction from an LDL of 100 isn't going to bring you down less than 70. So then you think, okay, what else can I use? Your PCSK9 inhibitors typically get anywhere from 50 to 60% LDL reduction. So you could say, okay, I could add it from my statin, I can add a PCSK9 inhibitor that'll get me less than 70. Or in the kind of the same in along the similar line is you could use something like inclisiran, which is our siRNA molecule. That gives you about a 50% reduction of LDL-C, also an injectable. So, okay, so those are two options for you. Now, if you have someone who's like, I am not doing an injection, no way, no shape, nothing, absolutely not doing it, then you start thinking, okay, can I combine ezetimibe and something like bempedoic acid? So the combination of Zetia and bempedoic acid, that will give you about a 35% LDL-C reduction. So you might be able to get there with that medication, right? So that's kind of the framework that I use is start with your statin and then see how much additional LDL-C reduction you need. It's also really important to remember that when you're doubling doses of statins, you only get another 6% LDL-C reduction for every time you
Okay.
double a dose. So just double, 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 double isn't always the right answer. A lot of times you need the synergy of both reduction of LDL-C and either upregulation of LDL receptors or blockage of lipid absorption at the level of the GI tract, right? You need something else. You need synergy. You need to be like firing on all cylinders. So that's usually the framework that I tell people to stay at.
That makes sense why you need to, because you were saying earlier how you need to understand the mechanism behind it,
Hmm.
right? Because the statins
Right.
are targeting one mechanism, and you're saying there may be multiple along that cascade that we need to do to get them to where they need to be.
Exactly.
Now
But that's where
once
these
you get
podcasts and
go
things
ahead.
come into play, right? That's where
Sure.
learning about the mechanisms and how to use them is going to be helpful to your practice.
Yeah. Yeah, totally. I agree. So I'm pretending that I'm a primary care physician, which I'm not, have got my patient down to my target level of 70.
Mhm.
And they come to me saying, I'm happy, I'm here. Okay, can I get off the meds? What do I tell them? And then how do I approach that?
Oh, it's hard. That is a challenging question. There are some people, and again, it's very individualized. Are you treating a genetic form of high cholesterol, or are you treating cholesterol that has been poor because of lifestyle changes, right? So people who have poor cholesterol and end up on medications because of poor lifestyle, meaning diet, exercise, and weight reduction has helped lower your LDL-C, then I'm going to give you a trial off of medication. Okay. People who have genetically determined high cholesterol, I don't take off med. And the reason why is because they have a fundamentally they usually have a fundamental problem with their LDL receptors at some level, right? Or they have a high Lp(a) or something, right? That I can't fix with diet and exercise. So by the minute you stop the medications, your body's going to keep doing what it's doing. Now, we could go down a whole nother kind of pathway with talking about CRISPR and where are we at with gene modification for, lipids, right? Where are we with that? And so that's a whole nother conversation. But if you have genetically determined high cholesterol, you're not going to come off meds. And if you've had a stroke, you've had a heart attack, you have peripheral arterial disease, or you have diabetes, you're also not coming off meds.
Okay. All right. Gotcha. So pretty much if it is hereditary or if you're at high risk, the conversation needs to be, no, this is probably something you're going to be on for the rest of your life, but
Yeah,
it's for a reason. It's to extend your life so you can have a longer life and a better quality life. Right.
absolutely.
Okay. I got you.
And if you're
Yeah, go ahead.
90 and you wanna come off of it, great. You know what I mean? If you are getting to a certain age and you're like, "I'm done with medicines, doc," then I'll respect that. Well, we can come off.
Sure. Sure. Now, with that being said, with all the stuff you're testing, it usually requires a combination of medications. And that can be one of the biggest challenges for patients is medication mismanagement. As far as they don't handle their medications properly, and then that actually leads to rehospitalization. Do you think that
Mhm.
there's any solutions out there? Because when you're saying we've had previous conversations about like CHF and how there's like a bunch of different medications they need to be on, right? For
Yeah.
cholesterol or whatever it may be, do you have any recommendations or symptoms or even thoughts of ways that we can improve it to reduce the chances of people mixing up their medications?
Yeah, absolutely. So, I mean, med boxes are really important. So pill packs are fantastic, or even the push packs where it's almost like a blister pack of your whole month of medications, because then it's a very visual, oh, I took my medicine today or I didn't take my medicine today. That's helpful. But if you want to change a dose, that can also get a little bit complicated with the pharmacies. So that's usually we reserve those things for people who are on stable doses. But I love those Monday through Saturday, Sunday pill boxes. I say use them if you're on more than one medication. The other thing is, sometimes utilizing a specialty pharmacies where they actually have someone who can call you and check in and say, "Hey, how you doing with your meds?" Right? I think there's even services out there nowadays where you have um, someone who is savvy with the medical field and understands medications. And there are some services out there that you can get someone to walk you through your medications and set you up for how to make sure that you're being successful with taking your medications. And so having a second set of eyes is not a bad thing when we're talking about medications. And I think that utilizing either family, friend, or even as, like I said, even a service, there are services out there that do this would be helpful. But if you're all alone and you don't have the resources, ask your pharmacy for a blister pack or a med box or to pre fill your whole month of your medications. And that'll help you be more successful. There are also
Uh,
some medications that are healthcare administered medications that might be better for you if you struggle with medication compliance.
what do you mean by that? What is healthcare administered medications?
Yeah, so healthcare administered medications are like, so as I was kind of alluding to before, the siRNA molecule inclisiran, that medication is an injectable medication to treat high cholesterol, and it is given once every 6 months, but it's given in the office, so it's given by a healthcare provider.
Okay, gotcha.
Yep.
Okay,
So you would come in and see my nurse or myself, and we would give you your injection, and then you'd go on your way.
okay, I gotcha. And then the
Yeah.
blister packs are just the ones that people pop out. They're already in one by
Yep.
one, right? Okay,
Exactly.
gotcha. All right. I want to move on because this is something I found. I was doing a little research and I want to know if there's any truth to this. So does high HDL actually reduce cardiovascular risk? Because what I was researching is that for a long time it's been considered the good cholesterol, but there is some research that says that very high HDL may not be as protective as we had once thought, and maybe even harmful. Is there any truth to that?
That's true. You're 100% correct. So, yes, a healthy amount of HDL is good for you, or it helps protect you in one semblance of a way. However, HDLs over like 80 milligrams per deciliter typically can increase your risk for developing heart disease. So we've seen this in studies. We've also seen in studies that drugs out there that raise HDL haven't been successful in reducing cardiovascular events. And so, yes, HDL can absolutely be helpful if it's in the right amount, but also could hurt you if it's too high. So you're right.
Mm, okay. So the ceiling that we're kind of looking at is like around. Yes, we want to always get
Around
your HDL
80.
up. No more than 80 though. 80 is kind of like where we want to say, okay, let's stop
Yeah.
there. Okay,
Yeah. The problem
gotcha.
is some people just have naturally high HDLs, right? Whether it be genetic or whatnot. And there's nothing out there. It's not like I'm going to put you on a drug to lower your HDL, right? But I am going to also be very careful with your risk assessment. And again, that's where like ApoB comes into play because your ApoB is going to look at all of your lipids, right? How many atherogenic particles you have, how many bad particles you have. So, what piece of that HDL is actually doing more harm than good?
Okay, gotcha. And then what about inflammation? Like, are we overlooking inflammation as a bigger risk factor for cholesterol?
I don't think that we're overlooking it. I think it's getting its time. I think inflammation is here. And I think people recognize that inflammation is bad. And we know that inflammation is the root of so many evils. You know, Smoking, right? That's the biggest thing one of the biggest things smoking does is creates inflammation in the body. It creates inflammation of the vasculature and the vessels. And plaque loves inflamed areas. Right? So where there's inflammation, plaque's gonna lay down. It also likes twists and turns, plaque, that's typically like where there's friction. And so I think that inflammation hopefully is getting its time. I mean, I see a lot more people talking about their inflammation and recognizing it. So I hope it's here. I hope we're not we're not missing it.
To clarify, you're talking more about chronic uncontrolled inflammation rather than just like an acute inflammatory state.
Yes.
Is that what you're saying?
Yep.
Okay, right?
Yeah,
Because
absolutely. So
there are times, yeah.
yeah, no. You're 100% correct. There's times where you have a cold, like you're going to have inflammation. That's not going to cause you to have a heart attack, right? Or you have a wound, or you had a surgery that you're healing from, or what I mean. You have kind of like inflammation for an acute cause. That's not the type of inflammation we're talking about. We're talking about underlying chronic inflammation due to certain disease states, or just due to kind of who you are.
Gotcha. Okay. Well, let's look to the future now. Tell me, what is something that like you're excited about as a lipid specialist and the way that we control cholesterol? What are some things in the future that you foresee coming in maybe the next 5 years and then maybe even like further down the road?
I'm really excited about the LP little a drugs. So it's something I'm super pumped about. I think that I want to see what the data shows. I want to see, does lowering LP little a make a difference? Is this the key to, changing the fact that heart disease is the number one killer of people? And so that's, hopefully we're going to have those answers in the next few years. And so I think that's one of the biggest areas of lipids that I'm really excited about right now. Some other areas of lipids I'm excited about is there's new medications coming out for triglyceride management, and there haven't been new drugs for triglycerides in quite a few years. So that's super, super exciting because a lot of patients who struggle with triglyceride management, there's not a lot of options out there. And so, like I said, I'm really excited about those medications. I'm also I think I'm really excited I mean, I'm a super nerd when it comes to lipids. And so I do think that there's this interesting topic of, like I said, hopefully, I don't think it's going to be within 5 years, but maybe some of this gene modification. And can we snip out PCSK9 from the liver, but only the liver, right? Like, can we do that? And what happens? People who were born without PCSK9, had really nice lipid panels and didn't have heart disease. But can we snip that out? I don't know. I don't know the answer to that one. But I'm really excited about the new triglyceride medicines. I'm really excited about the Lp(a) trials that are coming out. But I'm also excited about the awareness, and I think some of the education that's been coming out recently. So that's also something that I'm encouraged about, right?
Yeah, absolutely. For sure. I think, well, all those things you're saying for me personally, like the CRISPR sounds something like so cool, but it seems like that's in the more distant future. But
Yeah,
a really, really powerful technology that, of course, has a bunch of like ethical and moral challenges that we're going to have to
so
face as
many.
well.
Yep.
Right. So that's going to be a challenging one, but has a significant chance to significantly impact people's lives. Um,
Yeah. Like I
but
said, the nerd in me loves to talk about it, but at the same time, it's gonna be an uphill challenge.
Yeah, for sure, for sure.
Yeah.
Okay. Well, as we finish up this episode here, if there were any doctor or clinician that's looking forward to learning more about maybe how to manage the cholesterol or to manage their patients from a cardiac standpoint, is there any like resources or places that you recommend that they check out?
Yeah, so I recommend a lot of the resources I utilize are the National Lipid Association has great resources. American Heart Association has some really great resources. I also recommend utilizing ACC. So those are kind of like my top three if someone's looking to go. Look at there's a 2021 paper on triglyceride management that's really beautifully written. There's a 2022 expert consensus on non-statin lipid therapies for providers. There's in 2024, the National Lipid Association came out with Lp(a) recommendations. And so there's a lot of data that's updated regularly by the key thought leaders. And so I typically look to them, and I like to read the science. And those are the places I go to get it.
Oh, that's amazing. Well, I appreciate you sitting down and having this conversation because I know that so many people are trying to figure out what are the best ways to, it's such a common problem that we need to figure out. And picking the mind of someone like you that is specialized in this is like, it's really invaluable. So really, really appreciate it, Dr. Stephanie.
Well, thank you so much. I appreciate it. And, I really think that hopefully someone took a little bit of nuggets away from our talk today and, will help a patient who needs it.
Absolutely. And so as one last reminder, if you are a healthcare professional and you want to get some CME credit for it, we will go ahead. We will put the link below so you get access to it. And we're planning on coming out with a lot more cool stuff like this. So make sure to stay tuned. And until then, we'll see you soon.
We'll see you later.
I'm actually finishing up this podcast editing in a cafe, and I just wanted to thank you so much for listening along. The goal of this podcast is really simple: to bring on leading experts in the field and figure out solutions to challenges that we have in healthcare. If you wouldn't mind, we appreciate you following along as we're going to be having a lot more great episodes. And if you wouldn't mind rating or reviewing us, we really appreciate it as well. We'll see you in the next one.